Dr. Rajvi Mehta has worked in the field of ART for over more than 3 decades. She is an invited speaker at many conferences, including IIFS, Iran and ESHRE, and Germany. She's an executive member of Academy of Clinical Embryologists and in charge of IFS SIG on holistic medicine. She's currently the academic consultant to Copper Surgicals and scientific consultant to Trivector Biomed. Good afternoon, ma'am. I welcome you.
Good afternoon, Dr. Nidhi, and thank you for the introduction. So I will start my presentation on quality control in ICSI. And I must say that after Dr. Bindu's talk, where she convinced even all those who are not very convinced about the use of conventional IVF, that how important it is and how we need to continue working with it and the quality measures taken. In my talk, since we have many other speakers who will be speaking about the culture media, culture condition, a panel discussion, PGT, I'm going to focus primarily on ICSI and the quality control measures that go with ICSI. So to start with, I would like to start with the statement of Murphy's laws, which says that things will go wrong in any given situation if you give them a chance. And we all know, working in this field, that despite taking all the effort, sometimes things don't go the way we want. And sometimes, even if we have done everything right, there is nothing that has gone wrong, we don't get the desired results. And that is an accepted fact in ART. We all know that we are going to face disappointments for oftentimes no fault of ours. And we know that large number of our patients are going to go back unhappy because their happiness would be in getting a live birth, which does not happen. Maybe after in the first cycle, maybe after accumulated number of cycles. So taking that into consideration, that we may not always have success at that particular attempt, we don't want to be responsible for things that are not going right. And to me, therefore, quality control is reducing the chances of things going wrong, trying to do everything as right as possible and preventing anything that goes wrong because of unexpected reasons. Now, for that, we need to understand what is a realistic expected outcome. I mean, ideally, one can tell, a clinician can tell us, I want 100% fertilization rate, 100% blastocyst development rate. That's not realistic. That is desired outcomes, but these are not real. So we need to know what is a realistic expected outcome. And we also need to be aware of what can potentially go wrong. Things can go wrong. It's a massive process. ART, right from stimulation of the patient till ET or cryopreservation, warming and ET, it's a long process and anything can potentially go wrong. So we need to be aware of the entire procedure, which of course as embryologists, we do know the entire process and where is the highest risk of things going wrong. So even if we have a long drawn out process, we know that certain stages nothing can go wrong, but certain stages something will go wrong. And therefore we need to be proactive and take measures such that you can minimize this risk or this chance of things not being right. And as if anticipating a problem, we are a step ahead. So we know that this could be a problematic. It is like driving on the ghats of Mumbai, Pune, especially in the expressway days, where you had a hairpin bend. You would be warned this is an accident prone area. So we become more alert. And similarly here, we anticipate at certain situations there could be a problem. So we are prepared for it. We take measures to prevent it. And in case it does happen, we are prepared to reduce the damage that it can occur. So these are proactive measures to minimize risk and the potential outcome in case things don't go right. So this becomes a very important aspect of all biological treatments, all medical treatments, and especially ART, including ICSI. So now, what are the factors that affect the outcome of ICSI? And I'm talking of outcome of ICSI, not just, of course, the major outcome would be fertilization, but obviously the way we perform ICSI, the outcome of ICSI would be reflected in the quality of embryos, the blastocyst formation, and of course, the pregnancy rates. So considering that a lot of this is not just dependent on the procedure of ICSI, but ICSI does form a part of it, I'm going to restrict to factors which would be directly affected. So one is the quality of the gametes. Yes, if the gametes are compromised, if we are working with a very, very poor sperm sample, yes, that is the reason why we are doing ICSI. But then to anticipate, to get good results and poor oocytes combined with extremely poor sperms with no additional means of selecting the sperms, we may not be able to do much. Then it will also depend on the quality of the performance of the embryologist. After all, it's a highly skilled job, and how we work would determine the outcome. So obviously, a new embryologist, a trainee embryologist is never given ICSI because we know that the outcome may be compromised. And therefore, different professional bodies have laid down that you need to have a minimum amount of experience before you start working directly on patients. Then it is dependent on our tools, our equipment. I mean, even if in our highly skilled work, if our equipment is not of optimal quality, it is not maintained, it gives trouble, the tubings are loose, there is a leak, then we cannot function. So that equipment, quality of the equipment plays a role, and quality of the disposable media and reagents. You have expired reagents, or the disposables are not of that highest quality. They have, and can lead to contamination or toxicity. And of course, media, which I'm sure is going to be covered in one of the subsequent, and the quality of the medium and how we handle medium, which is possibly more important than, I would say, quality. Then also comes in the standardized operating procedure, because it is not just the skills, but the sequence in which we incorporate all the procedures. So if some shortcut is taken or something has been missed out, then that would be a problem, which would affect the outcome. So we need to formulate the SOPs and make sure they're implemented. So we can have SOPs on paper, that we have a very efficient management system, we have very efficient senior embryologists, lab directors who have made the SOPs, but are they being followed? Are they being implemented? Because otherwise they remain in the files, but those at the bench may do things which are not essentially desirous. So all this would affect the outcome. Now, if we look at specifically the processes which are specific to ICSI, well, it should start with oocyte denudation, because that's not something that's done for conventional IVF on day 0. So denudation is important. Then sperm selection. I'm not talking of sperm processing because it's the same method which is used whatever you're doing an IUI, IVF, or ICSI. Then the selection of the sperms, which to my mind is possibly the most challenging today. We try to select what looks best to us, and we do use additional tools like IMSI, PIXI are being used, but still we are not in a situation to select the best sperms. The immobilization, which is skill dominated, aspiration of the sperms, which is again partially skill dominated and also depends on the quality of the PVP, etc. Oocyte activation, which again depends upon the quality of the oocyte, some problems, and also skill of the operator. And finally, sperm injection into the oocytes. So any of these things, something can potentially go wrong. It could go wrong because of any of these few issues that I raised, and I'm going to specify again. So what do you mean by assessing quality? I mean, one can say, I get good pregnancy rates, I get good fertilization rates. What are you trying to assess? And quality is something which is very difficult to assess because it's so subjective, and you cannot have somebody standing over your head and seeing how you perform ICSI. Yes, that would be an indication how you're doing the procedure, but that will not indicate how good the entire process has been done. So to me, assessing quality is like quantifying quality, giving an objective value to a subjective entity like quality. And for that, we cannot directly quantify quality. So we have indicators. So how well ICSI has been done will be reflected in the oocyte damage rate, and it will be reflected in the oocyte fertilization rate. So you have performance indicators. Then what is it? I mean, should everything be 100%? As I said, that's not possible. We all know it's not possible. So you have standardized indicators. So there are so many performances like in the procedure. So we cannot look at each one. Possibly we'll spend more time in studying the performances rather than doing the procedures. So you identify key performance indicators, which are reflective of whatever we've done before that. Then we also need, so that is assessing the quality of our work. And we can compare that to national, international guidelines that have been laid, accepted values that are laid. And then we track what we are doing over time. So in that process, if something's gone wrong, we identify it much earlier than 20 days later when pregnancy rates drop. We identify it much, much earlier, but we keep tracking it over time to see why it has happened. And then we work on the different potentials for improving the situation from what it is. So now we come at performance indicators for quality in ART. So this is plotted over every month. And then one is performance of how injection has been done. So you can see that over a period of time, the intact oocytes were very low, about 80%, which is not really acceptable. It's quite, ideally you would expect much better intact oocytes. But over a period of time, they stabilized, and then there is a variation, because remember, injection is operator dependent, but the quality of oocyte is not operator dependent. You could land up with an oocyte, a particular individual or particular cause of infertility where they get affected. So we need to look at a trend. We can't judge on the basis of a single case. And then you can see that the incidence of normal fertilization also went up, and unfertilized oocytes, one pronuclear fertilization, is so much lower. So which was much higher in the early stages. So this is an indication of how ICSI has been done, which standardized and stabilized over a period of time. Now, as Dr. Bindu mentioned, we have the Vienna consensus, which is a consensus report coming from a group of highly experienced embryologists who decided how one performs in the lab and what is acceptable for providing treatment to the patients and what should be a benchmark. So basically, they have put in three kinds of indicators. One is reference, which is not directly pertaining to ICSI. For example, if you're having the number of oocytes, we compare that to the quality of stimulation or the response to the ovarian stimulation. Now, performance indicators is various steps that we do, and we note it down. So we don't really need to look at each and every performance that has been done, but the key performance, which are the ones which specifically affect the outcomes of an ART laboratory, which would be, say, the fertilization rate, embryo development rate, blastocyst development rate, implantation rate, post-vitrification, warming. So all these things would be considered. And for that, we have the minimum competency level. So it should be minimum at a particular level. And then you create a benchmark, which is what you aspire to be. So you don't aspire something like 100%, but better than your competency. And the competency mark forms the median line. And anything 2 standard deviations up and down is the variation that is acceptable. However, if it starts dropping down, we start getting alerted. So if we look here, this is the competency mark. And these two dotted lines are the benchmarks. Now there is a variation which is acceptable, but when it starts going down and reaching that bottom line, one becomes alerted there is a problem, and if we don't act on it fast, then we may have trouble. So this is an indication. However, if we are consistently going above the top standard deviation, and that means our benchmark is raised, we can even raise our own competency levels, because now our lab is performing well and we can raise our levels. So now if we look at the ICSI damage rate, here it is. Now in this case, you can see there is a variation. As I said, there are other factors which are beyond tools, equipment, and our cells which are responsible. So there is a variation. But when the damage rate crosses, so if 3.2 is the mean, then when it crosses 6, we know we are heading for some trouble, because now if we don't act now, if we don't look at the problems now, there will be more patients who would be affected, and immediately an action is taken, or at least to identify, and then there is a drop. So we set up the competency, set up the benchmarks, and constantly monitor them to why it is happening. Now, if you're looking at the ICSI damage rate, it is nothing new. It's a very common problem. It's experienced by everybody, and it's reported to vary from 15 to 19%. And the competency benchmark laid down by the Vienna consensus is 10%, and the benchmark is less than 5%. And we can set up our own competency and benchmarks in our lab. So you can try to be better and say, okay, in my lab, I am having only young patients, I'm doing ICSI for young patients, then I expect a higher benchmark. Now, if you're looking at causes for ICSI damage, what would it be? It could be, first, let's start with the first step, which is denudation. Now, if supposing an oocyte damage can occur during denudation, if by error, a small diameter denudation pipette is taken, so then we are causing mechanical damage. It could be the quality of the oocyte, as I said earlier, and also it could be the quality of the hydase or hyaluronidase that has been used. Maybe it's expired, maybe it has not been stored correctly, and therefore denudation doesn't occur correctly. Then there could be, so we need to check for it. Denudation pipette diameter, is it happening across patients, or is it just happening in one odd patient? So overall, our results do not get affected. But if it is happening across patients over a period of time, then we need to start looking at the stimulation protocol, because it's very unlikely that you're taking all those kind of patients at a time. And of course, look at the quality of the enzymes used. Now, one other potential cause, and often we always consider, is that it could be the embryologist. If something goes wrong, okay, it is the individual. The individual, yes, could be responsible, especially if we land up, it's difficult ICSI, and we'll end up doing a lot of manipulation inside the oocyte, the ulema would get damaged. And again, or the intracellular organelles will get damaged, or we may even move it to the other side. And that is surely going to impact the success rate of ICSI or totally damage the oocyte. In that case, if it's happening consistently, we cannot continue. The embryologist needs to be changed, trained, and retrained. But that should not be just a knee-jerk reaction. It should be thoughtful to see whether something like this is happening. Another reason would be the tools and the environment. For example, we don't have the right diameter ICSI pipette. We have it, but we possibly use something which was brought for something else. Vibrations, we use an anti-vibration table, but sometimes that could become a problem. You are skilled, the gametes are right, but vibration, and remember the pH, temperature, and osmolarity, they affect the gametes, especially the oocytes and the embryos. The environment, remember we are doing ICSI, and if there are VOCs in the environment, the dish is open, the VOCs can be absorbed by the oil and culture medium gets in contact. So we need to see that our environment has, if not zero, low VOC content, and especially if you're having trouble with our outcomes, and see whether the procedures are being followed or has there been any deviation in the SOPs. Like I said, we may set it up, but are they being followed? Then once you identify, check that, okay, which stage is the problem in ICSI? Has it happened during denudation, injection, or sperm selection, or where exactly has the problem occurred, or with the tools? And then you identify which is the potential cause, and then you start working on it. Do not forget that pH, we are using HEPIS buffered medium for ICSI. Therefore, it is much more stable than the sodium bicarbonate buffers. But remember, once the oocytes are denudated, they cannot regulate the internal pH. And internal pH, if it gets affected, if it increases, then it affects a lot of factors, which it will affect the oocyte developmental competence, the metabolism, and indirect after that, embryonic metabolism and intracellular organization. Remember, it is the oocyte intracellular machinery which plays a role till day 2, day 3, till the embryonic genome starts getting activated and starts being responsible for post-fertilization. And therefore, an damaged oocyte with reference to pH may have poor rate of blastocyst formation, blastomere division, fragmentation rates, and overall oocyte morphology. So we need to be careful on this aspect. And Dr. Bindu has already said, and I'm sure my subsequent speakers will emphasize on pH and osmolarity, how it is affected by temperature, by the droplet size, the volume, the oil overlay. So we cannot try to put a lot of droplets into one dish and take our own sweet time such that there is evaporation. Yes, droplets for ICSI are so small. So even micro evaporation would affect the osmolarity and affect the subsequent things. Now, what are the preventive measures which we can take? Yes, as I said, we have done everything we can, but there is still a potential risk. First is check the competency of an operator. Just because somebody walks into the clinic and said, I'm an experienced in ICSI, I have so much experience, you need to check the competency, see how many cases they have done. Also, training and retraining is essential. Sometimes, one is less trained and there could be problems. Sometimes one is extensively trained, but that can sometimes lead to complacency and shortcuts and deviation of the protocols. And this could lead to outcome. And maintenance of equipment, tools, and identify the source of tools and media. So for a clinical embryologist, what are the quality control? I would say training, yes, of course. Optimal workload. You may be very, very skilled, but if you haven't done anything for a period of time, then your skills will take time to surface. And at the same time, if you are overworked, then that is also going to be a problem. The working environment and working timings. If you're going to work till late night every day and still expect to come early in the morning, your efficiency would be compromised. And also this often happens when you're having visiting embryologists. For example, if for some reason the labs are not ready or the patient is not ready, things get delayed and you have in your back of your mind, you have to catch a flight, it can affect. So things in the laboratory, especially if you're visiting embryologists, need to be very, very highly maintained, and in fact, better maintained, I would say, than it would be in the conventional, where you have an in-house embryologist. So we need to assure ourselves that the clinical embryologist is having an ability to serve, and remember also a backup. In these times, we don't know when one may not be able to come, so we should have a
1 minute
backup plan.
remaining.
Yeah, I'm through. Then it comes to equipment. We need to maintain all our microscope, lenses, stages. We don't want any source of contamination because of microscopes and even micro manipulators. After all, they are tools, and you treat your tools with respect. It should be just common practice that when we end our day, all the control knobs are centralized, the tubings are well tighted, holders are very well thing. Now, for example, and if you are inserting the injection needle, how we hold it. It sounds very trivial when somebody says, but in the process, if our hands have moved to the top part, we are actually touching the needle, and we shouldn't be doing that. So, of course, we'll never be touching the tip, which is actually going to come in terms of the oocyte. But we should be staying away from the extremities and always have a good AMC with the manufacturers, because if things go wrong, we are going to be in trouble, because in the machine, the knobs are not smooth, we are in trouble. And coming to reagents, disposable, and media, make sure of the storage temperature, the equilibration of the media, preparation of dishes. Again, one, as I have already spoken of that, I will not emphasize. But these things are small things, the refrigerator temperature, all these things need to be taken into consideration. And as far as the SOPs, create, make them followed, and document. Because we may have SOPs in place, we have people are implementing it, but is it, what have you done? Is it put down into your system, either on paper or in the computerized system, and is it being analyzed? So don't analyze the problem because an external agency comes and asks you for your data. Your data is for yourself to internally audit and then compare it with the international KPIs or your set benchmarks, and to see how we are performing. So final question is, yes, we do a lot of quality management. Does it work? And yes, we do know that increased ICSI operator experience is associated with higher fertilization rate, because the chances of error, as I started with Murphy's laws, will be much lower. And in this particular study, which was done last year, an oocyte cohort was split into 3 embryologists, depending upon the experience. So this one had done less than 500 cases, 500 to 1,000 cases, and more than 1,000 cases. And you can see that the fertilization rate has improved. Obviously, it's not the fertilization rate, but the skills have played a big role in having higher fertilization rate. So all in all, ICSI is a demanding process, and to make sure that we do our best to prevent any chance causing detrimental effect in our work processes, we have a well-determined quality management system. And as I've already mentioned, 4 major causes, as long as we take care of that, then the problems can be well regulated and possibly avoided, and we can give the optimal chance to a patient. So thank you very much, Ahira, for giving me this chance on this interesting but challenging topic in all aspects. So thank you very much. Over to you, Nidhi.
Nidhi, Dr. Sanjay will take the questions. Okay.
Sanjay sir on the screen.
Thank you, Dr. Rajvi. This is one of the most important topic, I think, because the ICSI damage and ICSI quality control is something most of the youngster they tend to forget about, and they try to learn ICSI, they try to master it, and they just after completing their training, they believe that this is something very stereotype thing and they can master it very soon. But it's the other way around. And even today, I feel challenged every day whenever I sit to do an ICSI. I remember one of the classic paper, I think it was Diana Payne's paper, Why Do ICSI oocytes become dark?
Yeah.
And there were several factors enumerated in that. So I remember one of this, and I would like to ask you that question first. So how often is it that the spike or the barrel of that ICSI needle is blood. Because when you look at it from the angle that the inverted microscope gives you is different. And when you look at it from the other plane, it might not be as sharp as it appears.
True, it's a very practical problem and it's something, but I haven't really encountered that frequently. But I also realize that, how it is. I mean, if we're really going with the standard companies getting it, and most of the time, if the QC has been done, because in terms of needles, it's not possible for us to do a quality control, which we can even try for media. If you have doubts, we can have an overlapping batch. But for needles, that's each needle is different. So we can't really do our own QC. So I guess that is where it comes in, that we hope that's all. And in case there is trouble, we realize it, then it's best to change and not play around with the oocyte with reference to time and also the physical. That's what I would think. But generally, yes, with a good company providing a high QC levels, such kind of incidences would be less. So that's what I would say. But it's these are the things which can happen. And sometimes, when especially new, when one is very new, they may not even realize during the process of alignment itself, there's been chip and you don't realize it. And only when you magnify that, when you come down and you magnify, you realize, oh my God, it's not actually sharp. So it's also during the process. So the needle is fine, everything is fine, but during the process of alignment, something's gone wrong and you realize it much later after you've taken the gametes. So that can also happen. And it's totally invisible, at some even very low magnifications. At 4
True.
Or something, we can't see it.
Absolutely. Unless you change the angle, and it is possible only, I think, at microforge level, not at these. So another simple but practically important question is about the shaft of the ICSI needle. There are several types of ICSI needles available. So there are some needles which have longer shaft, but they are then a little malleable. And then there are some which are with short shaft and they are stout. So how do you give the preference choosing those needles?
I think finally it will depend on what one has been trained with and what one is comfortable with. The fact that we are provided with these, like, with these variables, indicate there must be few takers for what is not common. Like, to give you a very simple example, I mean, for a long time, I didn't know that you had a needle without an angle, 0 degrees. And you wondered that, how do you work with that? I mean, to have a straight needle without angle, how do you work with that? Because you're, okay, 30, 35, something like that. But I guess there are some takers who prefer the odd ones. I think I would just totally leave it to what one is trained with and what one is comfortable with. So it is because these are tools and I leave the tools to the person who is operating. There are some standard ones which you are comfortable with. Go ahead. And I don't think one should keep changing tools if things are going well. I think that is true for all of ART. Sometimes I feel that we are also, I would say, quite superstitious in a way. If things are working, we don't want to change the system because it's working, it's going satisfactory. Unless there is a strong reason to change, or we are very convinced that something new that has come in comes logically, physiologically, and the evidence provides that we may do better than what we are doing now, we may change. So I would state that let's not be jumping to things just because somebody else says so. If your system is not working well, definitely try new things. So I guess it's personal choice.
Time is
okay, Nidhi.
All right. So thank you, Dr. Rajvi Mehta, once again, exploring all the possibilities that may have an impact on the outcome of ICSI. Thank you very much.
Thank you, Dr. Sanjay. Thank you.
Thank you, Rajvi ma'am.